Okay, so this is going to be a quick talk on potassium imbalance, and unlike sodium imbalance, this is going to be a little easier because we don't really have to worry so much about the patient's volume state. So it's really just, is the potassium high or low, and if so, we go right at looking for the treatment, or looking for the cause. So an overview, your symptoms of potassium imbalance, like sodium imbalance, are going to be similar and non-specific. So we're not as so much concerned about the symptoms from the hyperkalemia or hypokalemia per se. They're not going to come right out and bite us. The main symptom for both is going to be muscle weakness. But the patient can present with the chief problem may be arrhythmia, or EKG changes. So what you're going to have to look at is the additional symptoms in addition to muscle weakness, besides whether or not it's there. And usually the symptoms are going to be pretty apparent on the history on the USMLE. So you should know the different causes of potassium imbalance. The most important labs to get for a patient with potassium imbalance are the CMP, of course, to check the potassium level, but also because you're going to want to know what the patient's blood glucose level is. You're also going to want to get an EKG on these patients, just because potassium imbalance is so apt to cause arrhythmias, and you're going to want to pay special attention to the width of the QRS complex, to the QT interval, and to the height of the T wave. So comparing hyperkalemia versus hypokalemia, as I mentioned, the symptoms are unspecific. Usually the USMLE just wants you to find the cause or know how to do a workup, and they want you to know how to treat the patient. So the different causes of hypokalemia can be vomiting, the use of diuretics, the use of insulin, high aldosterone state like Cushing's disease or Conn's syndrome, hypomagnesemia, or any kind of alkalosis. For hyperkalemia, the most common causes is the use of salt replacement, acidosis, any kind of renal failure, low aldosterone, the use of potassium-sparing diuretics, rhabdomyolysis, or a patient that's on a potassium chloride drip. We're not really going to talk about the patient that's on the potassium chloride drip because that's just iatrogenic hyperkalemia. So, but you should know that you've got to monitor your patients if they're on a potassium chloride drip because they may get hyperkalemia from that. So let's focus first on hypokalemia, and these are some hints to look at, both when you're approaching problems and while you're on the wards. And these might give you ideas of what the cause is. So if you have a urine potassium on the patient and it's abnormally high, you should think about renal losses, for instance, diuretics. If you have a patient that has hypertension, you should think of the possibility that they may be in a hyperaldosterone state. Remember that aldosterone causes the reabsorption of sodium in water, and because you're reabsorbing sodium, you're going to be kicking out potassium. So the patient will be hypokalemic, but they'll have a higher blood pressure. So Cushing's and Conn's are good to think about if the patient has hypertension, in addition to some of the other Cushingoid features that we'll touch on. If the patient has an acid-base disturbance on labs, if their blood pH is below 7.35 or above 7.45, in the case of hypokalemia, usually alkalosis, so above 7.45, you should think of GI losses, especially vomiting. If the patient is diabetic, then you should think of hyperinsulinemia because they probably have diabetes that they're have insulin that they're prescribed. And if the patient has a family history of hypokalemia, and usually you're not going to see this because patients usually don't remember, they'll remember their family history of cancer or of COPD or something of that nature, but they're not going to remember their family history of hypokalemia. But if they do, then Bartter syndrome or Gittleman syndrome is worth giving a thought to. If the history or physical points to possible bulimia, so in that case tooth erosion, if the patient's female and young, if the patient has a preoccupation with weight, or the USMLE throws at you the stereotype of cheerleader, then that should be you should think towards bulimia as a possible cause, and that's just because of the vomiting. So GI losses, this is particularly vomiting, sometimes diarrhea. The reason that this causes potassium is not because you're vomiting out potassium, but it's because you're losing acid from the body. And when you lose acid from the body, what's going to happen is that you're going to pull acid back out of the filtrate, and because of that, you're going to push potassium into the filtrate. Now, I can't emphasize enough that it's very useful to remember what the different channels are in the nephron. To know your sodium, potassium, ATPase, to know what all the different pumps are, your NKCC, your ENaC channel. The reason is because it's going to make things a lot easier for you if you in these different renal problems. But if you don't want to do that, if that's not your thing, then what you can do is just remember that alkalosis causes hypokalemia. So low protons causes low potassium. Hypokalemia causes a hyponatremic, hypokalemic metabolic alkalosis. And in this case, the alkalosis is metabolic. So the blood pH will be high and your bicarb will be high. And so in that case, because this isn't a respiratory alkalosis, your partial pressure of carbon dioxide will be normal or possibly high if you're compensating. This isn't going to be an alkalosis that you get because you're hyperventilating. You're going to have a normal to high partial pressure of CO2. So remember to distinguish between metabolic and respiratory alkalosis, because that might be how the USMLE poses this at you. Usually, if the patient has vomiting, it's going to be pretty evident by history. Vomiting is a common reason why people come in to the ED, or why you might be alerted over to a patient that's under your care. So generally, these patients are also going to need, in addition to correcting their hypokalemia, they're usually going to need volume resuscitation, especially if you're working in the ED and the patient comes in with a history of vomiting for the last 3 days. These are usually going to be patients that might be hypernatremic because or they may be normal natremic, but they actually are volume depleted. So any patient with GI losses, remember your ABCs and think that you may need to resuscitate this patient's volume. Okay, so the use of diuretics can also cause hypokalemia, and the reason for that is simple. Diuretics, at least the loop diuretics and the thiazide diuretics, which are the more commonly prescribed diuretics, they block the reabsorption of sodium. And so because you have more sodium in the filtrate, your sodium-potassium ATPase is going to become more activated. Remember that the sodium-potassium ATPase in the nephron pulls 3 sodium ions into the blood and kicks out 2 potassium ions. So if you have more sodium, you're going to be, as a result, kicking out more potassium into the filtrate and out the urine. And so anytime you use diuretics, you're going to block the reabsorption of sodium, and in addition, you're going to pee out more potassium. So loop diuretics and thiazide diuretics work on different transporters, but essentially they do the same thing. So this is a very common problem, as a lot of patients are on diuretics, but most patients are usually in the low normal range for potassium, so correcting their potassium is not something that we commonly have to do. But if the patient does have a potassium of, I don't think I gave you this, but the normal range for potassium is 3.5 to 5. You will be given that on the USMLE. If a patient with diuretics does have a potassium of less than 3.5, then you should address the hypokalemia, or if they have symptoms, of course. And that can be done with potassium replenishment orally. There are 2 congenital syndromes called Bartter syndrome and Gittleman syndrome, and all these is just hereditary disorders that essentially simulate loop diuretics and thiazide diuretics respectively. So remember that you have loop diuretics acting on a specific channel. They're activating that channel to reabsorb sodium, and then thiazide diuretics work on a specific channel, and that activates the channel to reabsorb, to block the reabsorption of sodium. In Bartter syndrome and Gittleman syndrome, what you have are defective channels, so you can't reabsorb the sodium as avidly from those channels. So it's kind of like you're on a loop diuretic or thiazide diuretic, respectively, all the time. And so these patients will have a congenital hypokalemia, and usually it'll be a hypokalemia that you work up and you just can't figure it out. So that's Bartter syndrome and Gittleman syndrome. And I'll show you a diagram at the very end, and you'll see the channels that are affected by these two disorders and by these two diuretics. So hyperaldosteronemia is another cause of hypokalemia, and the reason here is because, remember, aldosterone triggers the reuptake of sodium at multiple different sites, and because you're reuptaking sodium, you're going to reduce the charge of the filtrate. So you're pulling in sodium, which has a positive charge, and so you're causing your filtrate to have a net negative charge now. And what's the only other ion besides sodium that has a positive charge that can go out into the filtrate? It's potassium. And so the only way that you can cause the charge of the filtrate to become neutral again is to kick out more potassium. So that's what happens when you increase your reabsorption of sodium, is that you're going to kick out more potassium. And so these patients, because they have a high aldosterone state, they're usually going to present with other symptoms, and the most specific are going to be what you would have with Cushing's or Conn syndrome, where you have excess aldosterone due to either an ACTH secreting adenoma or an adrenal adenoma. And those are going to be your classic Cushingoid symptoms, which are weight gain, moon phases, edema, striae, menstrual irregularities, and even psychiatric symptoms like depression. The classic way to see hyperaldosteronemia and to really kind of nail that down and to be looking at that is when you have a patient with hypernatremia or hypervolemia, so they have edema, and then they have hypokalemia, and the patient is overweight, or they have edema, or they have some of these symptoms that come with a high aldosterone state, these other symptoms. And so Cushing's versus Conn's is really just a matter of where the ACTH or the cortisol is being secreted. The way you can do a workup for that is by an ACTH stimulation test, but we're not going to talk about this for renal. That's more of an endocrine thing. But just we do know that high aldosterone causes hypokalemia, and these are two causes of high aldosterone. Renal artery stenosis is another cause of hyperaldosterone, but the reason is not due to an adenoma. It's due to the fact that you have a stenotic lesion in your renal artery. And so if you have a stenotic lesion in your renal artery and you're not perfusing your kidney enough, you're essentially having pre-renal failure. So your kidneys are going to sense that your blood pressure is too low. And so it's going to activate the renin-angiotensin-aldosterone system, and you'll have high aldosterone. In these patients, you're not going to have Cushingoid symptoms. And so the way to tease this out is that these are going to be older patients with hypertension that's refractory. And it's not, you're using ACE inhibitors, you're using angiotensin receptor blockers, and it's not effective. And so the best way to think about this is that Cushing's and Conn's are usually going to be in younger patients without the risk factors for renal artery stenosis. And in patients with renal artery stenosis, they're going to be your diabetics, they're going to be patients with high cholesterol, they're going to be patients with a history of myocardial infarction or stroke or TIA, and that's how you can distinguish the two. But what they have in common is that all three of these do have a high aldosterone state. So this is a patient with Cushing's disease. It could just as well be a patient with Conn syndrome, but this is what she looked like 6 months before she developed the Cushing's disease, and then all of a sudden, she looks like this. it's hard to know that this isn't just a patient that's obese. But if she were to tell you that, if she showed you a picture and she said, "This is me 6 months ago," you know that this is not just her gaining weight. This is something else going on, because you don't gain weight this fast. What you could see, if you're really astute, but you'd have to be a master at this, is right beneath her eyes you see a little periorbital edema. But man, that's really just, you really have to kind of, I mean, it's obvious here because it says Cushing's disease underneath it, but periorbital edema is symptomatic of a high aldosterone state. So that might be a hint. But moon facies, I don't know, why they call it moon facies, but that's not a really reliable thing in the clinic. Just because having fat in your face because you're obese and having moon facies just look so similar. So what you're more going to rely on is the time interval between how fast she was this thin to where she is now. Another reliable thing is this buffalo hump here. Here we have, and it's kind of hard to see here too, but you have a fat pad above the neck, and so it's almost like a hunchback. And the really, really conspicuous symptom in high aldosterone is the striae. What you have is this red-purple marks, which you might think of as because this patient has stretch marks because the patient got fat so fast because of their Cushing's disease or Conn syndrome. But really what this is because you have high cortisol and high aldosterone, what's happening is that the integrity of the skin is being compromised. And so that's where these striae are coming from. Either way, if you think about it, either way, it's good to know that striae are associated with hyperaldosteronemia, because that's you're going to see this if you have a patient with Cushing's disease. You're going to see this to one degree or another. This is almost present in all of the patients that have this. And also, striae is something that the USMLE likes to bring up as a little buzzword. So hyperinsulinemia, the reason that this causes hypokalemia is because glucose is brought into the cells with potassium. So when your insulin is high, glucose is going to be brought into the cells at a higher rate, and it's also going to bring potassium along with it. So potassium is brought out of the blood and into the cells. And so these patients will have hypokalemia, but they'll also have a low blood sugar, and that's what's going to tip you off towards hyperinsulinemia. Hypoglycemia does have an array of symptoms. They're all nonspecific, but if you have a patient with irritability or fainting, that could be hypoglycemia, but these are really nonspecific. So they might present with that, but that's not going to necessarily tell you that they have hyperinsulinemia causing their hypokalemia. But good to know some of the symptoms of hypoglycemia, and it could be as bad as seizures. Usually the cause of hypokalemia caused by hyperinsulinemia is excess insulin injection. So these are your diabetic patients, your type 1 diabetic patients that have insulin on hand at home, and they just happen to inject themselves with too much insulin. Maybe they mismeasured it, or they miscalculated how much they were supposed to give themselves. And that's the most common reason why people would present with hypokalemia caused by hyperinsulinemia. Another way that you might see this, let's say that this patient isn't a diabetic. What you might see is what's called an insulinoma, which is a insulin-secreting tumor in the pancreas, or factitious disorder, which is a psychiatric condition in which the patient is actually injecting themselves with insulin. So what you would think is that, okay, how am I going to tell these two apart? They're both in non-diabetics. What you can do is you can get a C-peptide level, because I will tell you that factitious disorder, when patients inject themselves with insulin, that's actually pretty common. And so you're going to lean towards that first. But you don't want to just assume that, because if the patient has an insulinoma, you want to know. So what you should do is get what's called a C-peptide level. And what C-peptide is it's just this little tail protein that's on your own insulin that you make in your pancreas, not the injected insulin. And so if you have an insulinoma, what you would think is that you would have a high insulin level and you'd have a high C-peptide level because C-peptide is on your own insulin that you make in your own body. If you're injecting yourself with insulin, then your C-peptide level would be, I say low here, but it would be normal. It would be low compared to your insulin level, but you'd have a high insulin level and a normal C-peptide level, and low C-peptide level compared to your insulin level. That points to the fact that you're getting your insulin from somewhere outside of your body. Now, if the C-peptide level is low relative to the insulin, then you can pretty much diagnose factitious disorder. But if the patient's C-peptide level is high, that doesn't necessarily mean insulinoma because they could be taking the oral diabetes medications. So that doesn't necessarily mean insulinoma, but if on the USMLE you have a patient that has a high C-peptide level and a high insulin, then you should check for insulinoma. And the way you do that is just with a CT. You'll look in the pancreas, and if they have a mass there, that's probably insulinoma would be your definitive diagnosis. And you just consult surgery, and they'll take it out. And usually they have to do a Whipple procedure. So that's kind of a pain in the butt for those people, but that will be a cure. And this is not a metastatic tumor. So this isn't cancer. Okay, another big favorite of the USMLE is they like to tell you that a patient has refractory hypokalemia, you're giving them potassium, but it just keeps going back down, and you don't know what to do. Well, the probable cause of that is a low magnesium. It's not unusual for patients to be for them to have bad nutrition. So if you have a patient that has hypokalemia and it's refractory and you just can't get their potassium back up to normal between 3.5 and 5, the most likely cause is a low magnesium. So what magnesium does is it stabilizes the nephron and it reduces urinary loss of potassium. So if your magnesium is low, you're going to have an increased loss of potassium through your urine. What's important is that anytime you have a patient with hypokalemia, that you're also getting their magnesium levels right off the bat. Because getting a magnesium level on a patient, it's cheap. You already have drawn the blood. And if the magnesium level is low, then boom, that should be your first step, is to replace their magnesium and see if the hypokalemia corrects itself. And it's going to save you a lot of work, a lot of money for the patient, and it's very easy to fix. You can usually just give these patients oral magnesium, and 8 hours later, their potassium level is within the normal range. So keep in mind low magnesium. It's a classic board question as a cause for hypokalemia. And the reason, all right, I was kind of getting ahead of myself a little bit here. So when we get EKGs, what are we going to see in hypokalemia? If we have an EKG that shows changes due to the hypokalemia, it's going to be flattened T waves. You also might have a widening of the QRS interval. That's not so much present in this patient, but what you definitely see is the flattened T waves. What you also have, because you have a flattened T wave, is that the QT interval is prolonged. And yeah, it's hard to see that because the T wave is flat, and so how do you measure the QT interval? Just take my word for it. QT interval is prolonged when you have a flattened T wave. So the flat T wave is not so much a problem, it's the prolonging of the QT interval in hypokalemia. And the reason that's a problem is because of this. And what this is torsade de pointe. And this can cause death in the patient. So what we do for torsade de pointe is we give them magnesium, but hypokalemia can lead up to torsade de pointes. So this is why we get EKGs on these patients, is because we want to correct their potassium if it's too low, because this can be a deadly result. So, managing the patient with hypokalemia. So, this is going to apply to pretty much whatever the cause is. This is how we're going to manage them. We need to know the cause, because managing the underlying cause is important. That's always part of the plan. But we have to replenish the potassium. So first off, always make sure you have an EKG on these patients. That's going to tell you how emergent this replenishment is. If the patient's asymptomatic, so let's say that they're in the hospital for something else, and your CMP one morning comes back as a potassium of 3.3, you can just give the patient oral potassium replacement. You don't need to start IV fluids if they don't have it already. You don't need to give them IV potassium chloride. You can just give them oral potassium replacement if they're asymptomatic. So if you get a question on the USMLE and it tells you the patient's in for another reason, and all of a sudden you get this potassium level of 3.3, but the patient has no other symptoms, go ahead and just give them an oral potassium replacement. It's cheaper. This patient's going to be fine. The GI tract is very good at absorbing potassium. If the patient does have symptoms, or they have any of the illnesses that was described before that I mentioned, like the GI losses or the hyperaldosteronemia, then what you should do then is, along with their maintenance fluids, you should start potassium chloride at 10 to 20 milliequivalents per hour. And we don't want to go any faster than that, and primarily it's because potassium chloride is really irritating to the vessels, and you can clot off your IV. So 10 to 20 milliequivalents per hour is generally fast enough. We don't want to use sugar-containing fluids, so if they are on IV dextrose or on Ringer's lactate, we would want to switch that to just general half-normal saline. And the reason is because anything with sugar in it is going to raise your blood sugar, and what's that going to do? That's going to increase your insulin, and what does insulin do? It causes sugar and potassium to be pulled out of your blood into cells. So we don't want that to happen, because this patient already has hypokalemia. So don't use sugar-containing fluids in patients with hypokalemia. Of course, we want to replenish their magnesium if it's low. We can do that either orally or with IV Mag Self. And then we'll want to get serial CMPs on these patients to monitor their potassium, and be sure to avoid the iatrogenic hyperkalemia. You don't want to give them too much potassium chloride. Okay, so moving on to hyperkalemia, so these are some of the hints for hyperkalemia. First off, medication history is very important in the patients with hyperkalemia. So not so much in hypokalemia, but in hyperkalemia, there's lots of drugs that can cause hyperkalemia. ACE inhibitors, NSAIDs, of course the potassium-sparing diuretics, acetazolamide, which is it's a diuretic, but it blocks at the proximal tubule, and so that can cause metabolic acidosis, which itself causes hyperkalemia. Antipsychotics, and the reason for that is because it causes neuroleptic malignant syndrome, which causes rhabdomyolysis, which causes hyperkalemia. The statins, that causes rhabdomyolysis, and then beta blockers, because it blocks the absorption of potassium in the body in general. So what you should ask yourself in any patient with hyperkalemia first is the patient hypotensive, and are they hyponatremic? If they're hypotensive and hyponatremic, you should consider Addison's. And we talk about Addison's more in the sodium imbalance slides, but anytime a patient's hypotensive and they're hyponatremic and hyperkalemic, definitely Addison's is what you should think of. And think about that. Hypotension, hyponatremia, and hyperkalemia, what is that? That's the opposite of hypertension, hypernatremia, and hypokalemia. And what's that? That's Cushing's or Conn's, high aldosterone state. So just the flip-flop of that. We should ask ourselves if the patient has a recent history of seizures or muscle injury, or if they're on statins. those can all cause rhabdomyolysis, and that's an emergency. So we treat that a little differently because it has other implications. Ask yourself if the patient's respiratory rate is elevated. If they're respirating at 22 breaths per minute, they may have a metabolic acidosis. So you may want to get a blood pH on this patient to see if they are in acidosis, because that can be a cause of hyperkalemia. Remember, I said alkalosis causes hypokalemia. The same thing. Acidosis causes hyperkalemia. Ask yourself, is this patient functioning renally? Do they have a high BUN or high creatinine? If so, you should consider renal failure. Your kidneys are responsible for getting rid of potassium. If they're not functioning, potassium is going to build up in your blood. And then, of course, ask yourself if the patient has cancer. Remember that tumor cells, like any other cell, have potassium in it, high levels of potassium in it. And so if the patient is on chemotherapeutics, if they have cancer, then tumor lysis syndrome is a possibility. And what you're going to have is similar to rhabdomyolysis. The patient's going to be just spilling potassium out of these cells that are dying. And so that's something to think of, is tumor lysis syndrome. So the first thing to think of, and you're probably not going to get this on the USMLE, but it's so god-awful common in the wards, and that's salt replacement. So what you get is these patients that have been told repeatedly to keep a low sodium diet. And what they do is they go to the grocery store and they see something like Mrs. Dash. And what is Mrs. Dash? It's the flavor enhancer that doesn't have any salt in it. Well, yeah, it actually does have salt in it. It has potassium in it. And these patients think, oh, this is great. I can just shake this all over my food and I'm not going to raise my blood pressure. Well, true, they might not raise their blood pressure, but if this patient has any kind of declined renal function at all, even if they're just an older patient with normal decline in their renal function, they can get hyperkalemia, and they can even get symptoms from their hyperkalemia. So this is actually really common. You're going to see this on the wards, guaranteed. But on the USMLE, it's probably going to be a little too obvious. It's difficult to make a question out of this. But just keep in mind that this exists. If not for the USMLE, for your own knowledge, for your real practice. So hyperkalemia caused by acidosis, this is kind of complex, the reason this happens. Remember that acidosis causes hyperkalemia, but I'll show you a little diagram of it, and so you'll kind of have a visual of why this happens. It'll make a little more sense. What happens is that when you have acidosis, you're going to have a more acidic filtrate running through your tubules, and because you have more hydrogen in your filtrate, the activity of the hydrogen sodium pump in your collecting duct is going to increase. And so what the hydrogen sodium pump is it pumps hydrogen into the filtrate, so you're getting rid of your hydrogen from your blood, and pumps sodium out of the filtrate. And so because you have so much hydrogen already in your filtrate, you're going to activate this. You're pumping hydrogen out of your filtrate and sodium into your filtrate. So because you have a lot of hydrogen, you're going to pump hydrogen back in and sodium out. And I'm screwing this up really bad. This is why you need to have a picture. So let's just look at it here. Hydrogen is going into your filtrate and sodium's being reabsorbed. So it makes sense that if you have acidosis, hydrogen is going to be going into your filtrate because you have acidosis. So hydrogen's going into your filtrate, sodium's being reabsorbed. From the point where you have sodium reabsorbed, your sodium-potassium ATPase is going to be slowed down. And so you're going to retain more potassium. I will show you a diagram of this at the very end, and it'll make perfect sense. The visual is always easier than thinking about this intuitively. So this is going to present as a metabolic acidosis. Usually the people who have hyperkalemia that also have acidosis are going to have metabolic acidosis. So they'll have a pH that's low, a bicarb that's low, and a PCO2 that's low if they're compensated. What you should consider for these patients is any cause of metabolic acidosis. So anytime you have metabolic acidosis, first thing, check your anion gap. If the anion gap is elevated, think of mud piles. So your elevated anion gap metabolic acidosis will include methanol, uremia, diabetic ketoacidosis, propylene glycol, inborn errors of metabolism, lactic acidosis, and ethylene glycol. And then if it's a normal anion gap metabolic acidosis, then good to think of the renal tubular acidoses, which I'll address in a different section. If the patient has renal failure, that should be your first thought. If they have hyperkalemia and they have renal failure, immediately think that the renal failure is the cause. Our kidneys are our only way of getting rid of potassium, and we usually consume way too much potassium than we can handle, so our kidneys are responsible for kicking out the potassium that we consume too much of. So if your kidneys are failing, you're going to have too much potassium in your blood, you're not going to be filtrating, and so definitely look for a patient with a history of renal disease, which will be demonstrated by an elevated creatinine and BUN in your labs. And these patients are going to need dialysis. If they're on the potassium-sparing diuretics, that can cause hyperkalemia, and the reason is because the potassium-sparing diuretics block the epithelial sodium channel, ENaC, and because that happens, you're going to have higher amounts of potassium going back into your blood. So if the dose is too high, you can have hyperkalemia. So look for a patient who's just been started on a potassium-sparing diuretic, or they've just had their dose increased. And the potassium-sparing diuretics that you're going to see prescribed are enmilaride and triamterene. And in these patients, you're going to have to discontinue the diuretic before you treat their hyperkalemia, or while you're treating their hyperkalemia. The most serious hyperkalemia is rhabdomyolysis. So what this is a precipitous breakdown of the muscle. And like any cell, muscle cells have high content of potassium. So when they break down, the serum potassium is going to rise really fast. This is a life-threatening condition, and mostly it's directly due to the hyperkalemia. Because your blood potassium is going to rise so fast in rhabdomyolysis, you're at a very, very big risk to go into asystole. So you definitely need to get an EKG on these patients as soon as you think that a patient has, if they have a high potassium and they have any of these risk factors for rhabdomyolysis, get your EKG right away. So crush injury, so if they had their leg run over, like their thigh or something like that, not if they slammed their finger in the door, but if they had their thigh or their arm broken, definitely think of that. If excess exercise, especially if they're dehydrated, statins, prolonged fixed position, so think of a patient that fainted and was out of it for 20 minutes, 30 minutes. If they had a stroke, patients who have had seizures for a long time, so status epilepticus, neuroleptic malignant syndrome, which is the adverse effect of antipsychotics, and various infections. Definitely get your EKG stat. Once you've done that, then you can start treating the rhabdo itself. So this is an EKG in a patient with hyperkalemia, and what you see here are peaked T waves. So you also see a widened QRS complex here, but the peaked T waves are what's going to be what gives it away. So look at this on V4. The T wave is actually taller than the QRS complex. And you know this is your T wave here because it doesn't go down into the negative territory. So here's your QRS complex, and here's your T wave right here. Here's another T wave, that's too big. Remember, the T wave, if it's in your limb leads, if it's anything bigger than half of a big box, it's too big. In your precordial leads, if it's anything bigger than one big box, it's too big. All right, so managing the patient with hyperkalemia, I know I've said this a lot, but it can't be emphasized enough. Always get your EKG immediately if the patient has hyperkalemia. If the EKG is abnormal, and anytime the patient has rhabdomyolysis, start your IV calcium chloride. What that does is it stabilizes the heart and reduces the risk of an asystole or fibrillation. After that point, you can start your maintenance fluids. I would just use regular half normal saline, and also use glucose. So you can use dextrose for that matter. So you can use your D5 half normal, but add some glucose to this patient and it's not so much that you want to give them glucose, it's because you want to give them insulin. Remember what insulin does? It pulls glucose in with the potassium. And so if you have a patient with hyperkalemia, insulin's going to be useful because it's going to pull potassium out of the blood. You can add sodium bicarb to the patient's IV fluids, especially if they are the patient that's got acidemia. But start a different IV line. Don't piggyback this on to your maintenance fluids or where you've given the calcium chloride, because what happens when you add calcium chloride to sodium bicarb is that you get calcium bicarb, and that's going to be crystallized. So you will clog up your IV. So maybe start an IV on one arm and start another IV on the other arm for your sodium bicarb. You can use diuretics, K-oxalate, to prevent absorption. Remember, diuretics, don't use the potassium-sparing diuretics, but you can use loop or thiazide diuretics to reduce potassium. You can use K-oxalate to prevent absorption in the GI tract. And of course, in emergent situations, dialysis can be useful. Just some general housekeeping. You're going to want to keep them on heart telemetry monitoring as long as their potassium is high, because they are at risk for developing EKG changes down the road as long as their potassium is high. So just because they had a normal EKG doesn't mean that they're out of the woods. So you're going to want to make sure that you have these patients on tele. You're going to want to make sure that these patients are on a low potassium diet, and you're going to want to check their potassium levels every 2 to 4 hours. In the patients who have rhabdomyolysis, or where that is the presumptive diagnosis, you're going to want to keep an eye out for compartment syndrome, because that can worsen the rhabdomyolysis. So make sure you do a good neurological exam on these patients. And I believe that is all I have for you. Oh no, I'm sorry. I have this that I promised you earlier. So this is that the reason that when you have acidosis, you will develop a increase in your potassium, or if you have an alkalosis, you'll have a hypokalemia. So right here's your, so outside of the filtrate here is your blood. Anything outside is your blood. So let's say you have alkalosis. What's going to happen to this channel? This channel is going to increase in activity, because alkalosis, you're going to pull hydrogen ions out of the filtrate, and so you're going to be pumping out sodium, and because you pump out sodium into your filtrate, so sodium's going to be pulled back out of the filtrate, and this sodium-potassium ATPase is going to be activated, and so ultimately what happens is potassium goes into the filtrate. So your sodium is going to be pulled into the filtrate by the hydrogen sodium pump, which becomes more activated by the alkalosis, and so as a result of that, your sodium is going to be pulled back into your blood out of the filtrate by the sodium-potassium ATPase at the expense of potassium, which goes into the filtrate, which will ultimately be lost. So alkalosis equals loss of potassium or hypokalemia. The exact opposite if you have acidosis. If you have acidosis, do you think that this channel is going to be active? No. You already have a lot of hydrogen ions in your blood. So this channel is going to be working very slowly, if at all. So you're going to have very low sodium this is going to be working very slowly, so you're going to have lower sodium in your filtrate, and because you have lower sodium in your filtrate, the sodium-potassium ATPase is not going to be working fast at all. It'll be working slow, so your potassium is going to stay in your bloodstream, and so that's why the acidosis causes hyperkalemia. So if you visualize it here with this diagram, it becomes much more obvious. We will revisit this diagram when we talk about renal tubular acidosis, but you should know these basic channels because it's going to make things make a lot more sense. And you can see here I put what's affected by the loop diuretics or Bartter syndrome, what's affected by the thiazide diuretics or Gittelman syndrome. You got your carbonic anhydrase inhibitors. This is the reason why carbonic anhydrase inhibitors can cause metabolic acidosis. You got your potassium-sparing diuretics working on ENaC, and then I also, we didn't talk about these, but here's your type 1 and type 2 renal tubular acidoses, and where aldosterone works and where ADH works. So, good to know the architecture of the nephron. And I'll see you on the next section.